Hi everyone, Zama Kweyama here, and I'm going to be doing a presentation on the approach to the patient with myelomeningocele. So myelomeningoceles are central nervous system birth defects that fall under neural tube defects. Neural tube defects can be divided into open and closed defects and into cranial and spinal defects in terms of location. Open neural tube defects can be found anywhere on the central nervous system. They can be both cranial and spinal in location. Open defects can occur as a result of failure of neural tube closure along its dorsal axis. This leads to exposure of the spinal cord and its meninges. So classification of neural tube defects in terms of cranial dysraphism and spinal dysraphism includes these type of conditions. So under cranial dysraphism, we have anencephaly. In anencephaly, the baby is born without a significant part of the brain, the skull, and the scalp. This occurs as a result of failure of closure of the cephalic part of the neural tube. And then in encephalocele, this is protrusion of the brain through defects in the skull that form sacs that protrude with its membranes. And then craniorachis totalis, this is the most severe form of neural tube defects. It's failure of the neural tube to close both cranially and caudally. And it's basically both anencephaly as well as spina bifida. And then your congenital dermal sinus. This can be both cranial and spinal as well. It can be found anywhere on the nasal, from the nasal to the occipital region and then to the lumbosacral spine. This is caused by failure of the ectoderm to separate from the neuroectoderm, therefore forming a sinus between the two. It can present as a dimple, a skin tag, or a local infection, or a lipoma, or a hemangioma. It's also associated with neurological fallouts or infections. And then under spinal dysraphism, so spina bifida aperta, which is basically a myelomeningocele or an open spinal defect. And then spina bifida occulta is a closed spinal defect. And then spina bifida in relation to a dermoid cyst. Here, dermal contents invaginate into the neural tube during development, and then they form benign tumors later on in life. They usually present after repair of a meningomyelocele, and they present as neurological fallouts as the cysts grow and compress the nearby spinal cord. And then split cord malformations. So here, the baby is born with a split spinal cord or a duplication of the spinal cord, and it results in a hemicord. And then diastometomyelia is splitting of the spinal cord. It usually occurs at the upper lumbar region, and the split components fuse distally. Would have been better if I had photos. And then the diplomyelia, so this is a congenital true splitting of the spinal cord. Each has its own membranes and nerve roots. And then in caudal agenesis, this is the distal portion of the spine fails to form. So in its most minimal form, it's only the bones that are involved. So the babies are born without a sacrum, but it can involve the kidneys, bladder, lower limbs, hind gut, and the caudal spinal cord. And then lipomatous malformation, so it's a form of closed spinal neural tube defects with lipomatous tissue in the spinal cord or filum terminale. It can be subcutaneous, intradural, transdural, or non-contiguous. So myelomeningocele is a form of spinal dysraphism, also known as spina bifida. There are two types of spinal dysraphism. There's open and closed defects. Open spinal dysraphism comprises of a malformation in the vertebral column that is associated with a defect in the overlying skin, which leads to exposure of the meninges and the spinal cord. This is the most common type of neural tube defects, and it's also known as a myelomeningocele or spina bifida aperta. Closed spinal dysraphism comprises of a malformation in the vertebral column that is not associated with a defect in the overlying skin. Therefore, the meninges and spinal column are not exposed. This is also known as spina bifida occulta. In terms of pathophysiology, so neural tube defects are one of the most common congenital birth abnormalities. During embryogenesis, the formation of the central nervous system is called neurulation. So neural tube defects occur as a result of an abnormal neurulation process. This disruption usually occurs in the 3rd and 4th weeks of embryogenesis, prior to closure of the neural tube. The process of neurulation comprises of a primary phase and a secondary phase. So in primary neurulation, so the ectoderm forms a plate, which is called the neural plate, in which the central nervous system develops. So in the beginning of the 3rd week of embryogenesis, the neural plate forms folds on either side, which grow upwards towards each other and fuse to form a neural tube. Fusion starts in the cervical region and continues in both the cephalad and caudal directions. As fusion progresses, the neural tube forms a cranial and a caudal core. So as you can see in these slides, so there's your neural plate, and then on its lateral edges, it forms folds that fuse to form a neural tube here. And then here on this side as well, you can see, so the folds come together and they fuse in the cervical region, and then they continue to fuse both in the cephalad and the caudal directions. And here you have your cranial and your caudal neuropores. So the cranial neuropore closes on the 25th day, while the caudal neuropore closes 2 days later. So myelomeningocele occur as a result of failure in primary neurulation. This is failure of the neural tube to close by the 4th week of embryogenesis. And then in secondary neurulation, this is formation of the distal spinal cord, caudal to S2. It forms the tip of the conus medullaris and the filum terminale. And this occurs beneath the ectoderm. Therefore, abnormalities in secondary neurulation will be covered by skin. So in this picture, so you can see spina bifida occulta. So there's vertebral abnormalities or defects, but it is still covered by skin. And then in your meningocele, so you can see there's a defect in the vertebral column, and then there is protrusion of the meninges. And then in your myelomeningocele, there's a defect in the vertebral column, as well as protrusion of the meninges and the spinal cord, and there's a defect in the skin overlying the defect. And then here's another picture here. So here you can see some open neural tube defects. You can see protrusion of the spinal cord and its meninges, and beneath it will be the vertebral defects. This is the same. Okay, so in terms of etiology, so neural tube defects have been shown to be caused by deficiency in folate. So this can be due to either inadequate intake, absorption, or use of folic acid antagonists in the form of drugs, so anti-epileptics, such as your valproate, carbamazepine, phenytoin, phenobarbital, and methotrexate. And then genetically, so open neural tube defects have been shown to be more common in females, and there is an increased risk of recurrence within families. So the risk has been shown to be 1 in 20 in one previously affected pregnancy, and then it increases to 1 in 10 in 2 previously affected pregnancies. MMCs have also been shown to be associated to some genetic syndromes, such as your Meckel-Grubler syndrome. So this is an autosomal recessive disorder, which is characterized by an occipital encephalocele, polydactyly, as well as cystic kidneys. This syndrome has a poor prognosis. Roberts syndrome is also an autosomal recessive condition, which is characterized by facial and limb abnormalities. Draco-Levin syndrome is characterized by abnormal formation of the spinal cord and the rib cage, and these children usually have short necks and restricted movement and breathing difficulties. So MMCs have also been associated with hydrocephalus, agyria, and retinal dysplasia, as well as trisomy 18 and trisomy 13. So they've also been associated with amniotic bands. So these bands interfere with the neural tube development, which leads to neural tube defects. And it's also been associated with pregestational diabetes. So this is related to the control in pregestational diabetes. So the risk is higher with poorly controlled pregestational diabetes. So the risk of having a child with neural tube defects is 2 to 10 times higher in these patients. And then the risk in mothers with gestational diabetes is lower, though. It can be as low as in the general population. MMCs have also been shown to have relation to obesity. The relationship is not well understood, but a link between the two has been found. So some studies mention that the relationship was not direct, but it's more so that neural tube defects can be missed in the screening process due to poor visualization. Also, high BMI and larger blood volume causes abnormally low levels of maternal alpha fetoprotein, which can lead to neural tube defects being missed during screening. And then maternal fever in the first trimester has been associated with neural tube defects, cleft lip and palate, as well as congenital heart disease. The mechanism, time, and duration of the fever is poorly defined, and this fever can be secondary to infection or being in hot tubs, a sauna, or tanning bed. Neural tube defects have also been shown to be related to the use of dolutegravir. So there's a Sapamo study that was done in Botswana, which found that the risk of neural tube defects is higher in mothers that are on dolutegravir in the periconception period or at 6 weeks or less gestational age. The risk was compared to mothers who were on the efavirenz-based regimen. So the risk of neural tube defects increased from 0.1% in the efavirenz-based regimen to 0.3% on the dolutegravir-based regimen. In terms of prenatal diagnosis, so our screening test includes an ultrasound. Ultrasound is done between 8 to 12 weeks, and if this ultrasound is normal, a repeat can be performed at 18 to 20 weeks. This allows time for further diagnostic tests to be done should the ultrasound be abnormal. We can also measure alpha fetoprotein. This can be measured in the maternal serum, known as maternal serum alpha fetoprotein, in the amniotic fluid or in the fetal plasma. Alpha fetoprotein is a globulin produced by the yolk sac, liver, and the gastrointestinal system. It's best measured between 16 and 18 weeks gestational age, but can be measured earlier in up to 20 weeks gestation. It's considered abnormal if it's more than 2 to 2.5 times higher than the normal value, and this value is correlated to the time of the gestational age during sampling. We can also screen for genetic syndromes, but this is only indicated if the screening tests are positive. So if the ultrasound and alpha fetoprotein are suggestive, then we can also screen for genetic syndromes. Fetal MRI can also be performed, but this is usually done if the ultrasound did not give a clear diagnosis and alpha fetoprotein levels are abnormally high, and if the findings are likely to affect the management of the pregnancy, for example, in genetic syndromes that are incompatible with life. Once MMC or neural tube defects are diagnosed, we need to have close maternal follow-up and fetal monitoring. We need to plan for delivery in a center of care that will have the available resources to manage the newborn child, as well as to do the necessary referrals and maternal counseling and preparation for the birth of a child with neural tube defects. So in terms of prenatal management, fetal surgery can be done, and this can be either open repair in the form of hysterectomy or a repair via fetoscopy. This is performed before 26-week gestational age. So closure of the MMC prevents complications associated with MMC, such as Arnold-Chiari malformation and therefore hydrocephalus. This then also reduces the risk of having a VP shunt insertion in the future. And closure of MMC prenatally has been shown to have improved neurological outcomes in children compared to those that have a post-natal repair. In terms of complications of fetal surgery, they include preterm labor, abruptio placentae, or increased need for cesarean section. Clinical features of MMC in the newborn. So there'll be a defect in the skin overlying the spinal cord, the defect in the vertebral column. There'll be exposed meninges and spinal cord with CSF enclosed in a membranous sac. The defect is usually over the lumbosacral region 80% of the time, but it can be anywhere in the spinal cord. And this is because the lumbosacral region is the last segment of the neural tube to close. There can also be paralysis depending on the level of the lesion. It can be complete paralysis or motor with some sparing in sensation. There can also be loss of bladder and bowel control, which will be evident later on in life. So if the MMC is associated with Chiari-2 malformation, it leads to brainstem and upper cervical nerve dysfunction. So this will present in the form of difficulty swallowing, paralysis of the vocal cords leading to stridor, apnea, nystagmus, upper limb weakness, strabismus, and facial weakness. These babies can also have signs of hydrocephalus. So clinically, we also screen for associated abnormalities. So cardiac, we can screen for any congenital cardiac abnormalities, listen for murmurs, and visualize on chest x-ray for any visible abnormalities. Renally, they can also have hydronephrosis, horseshoe kidney or pelvic kidneys. And then they can also have GIT abnormalities and orthopedic abnormalities such as your hip dysplasia, club feet, contractures of the hips, knees, and ankles usually. So in terms of investigations, the gold standard is MRI, so we can visualize the neural tube defect or the myelomeningocele and all its components. And then we can also do an echo for screening purposes in terms of associated defects. We can also do x-rays to visualize the vertebral defects as well as the associated orthopedic complications. And then in terms of your baseline blood workup in preparation for surgery for closure of the MMC, so we can do a full blood count with a differential count, a urea and electrolytes, as well as your infective markers, as these babies are prone to infection. And then you can also do a genetic workup if it's indicated. So in terms of management, so generally, management of patients with a MMC involve a multidisciplinary team. So this will include your pediatric neurosurgery, pediatric neurology units, your pediatrics generally, urology as well as your allieds, physiotherapists, occupational therapy, dietitian, speech therapy. And then the initial examination of the MMC should be done in a sterile manner. So you need to document the size and the location of the lesion. A sterile gauze, which is soaked in saline, is used to cover the defect, and if it's big enough, you can also cover the defect with that, as well as a plastic dressing. In terms of management, continuing, so we nurse the babies prone or on their laterals to avoid exerting pressure on the lesion. We can also give them prophylactic antibiotics for infection prevention until the defect is closed. You do neurological observations as they can deteriorate at any time, and this needs urgent referral to neurosurgery for closure. In terms of the surgical management, so closure of the MMC is usually done in the first 72 hours of life. This decreases the risk of infection, and the procedure includes approximation of the lateral edges of the neural tube defects. And complications include CSF leakage, infections such as meningitis and wound sepsis, as well as dermoid inclusion tumors. Neurological complications include hydrocephalus. So serial monitoring of the head circumference should be performed post-closure of the MMC. If the head circumference is rapidly increasing and the patient is symptomatic, insertion of the ventricular peritoneal shunt is indicated. So these symptoms will include vomiting, poor feeding, stridor, apnea. And then VP shunt insertion can also be done for cosmetic purposes. Like if the head is significantly larger than the body, VP shunts can be inserted. And then complications of VP shunt insertion should be noted and explained prior to insertion, so such as shunt blockage or malfunction, and as well as sepsis. So shunt malfunction, if there's a decline in function, it can be linked to a shunt malfunction. So therefore, regular review and follow-up is important. Children can also present with seizures. So once we have done a workup for the seizures and excluded all other causes, we can consider shunt malfunction as a cause, or epilepsy. Epilepsy is associated with neural tube defects and hydrocephalus, so then we treat for the epilepsy. They can also have learning difficulties. The risk is increased secondary to hydrocephalus, meningitis, or Chiari formation, altering brain growth. A routine screening is to be done at follow-up, and relevant referrals, once identified, to be done so that we can start treatment as early as possible. Neurological complications continued. So a tethered cord. This is abnormal stretching or fixation of the spinal cord. It can present as lower limb weakness, pain, changes in bladder and bowel control. Treatment is surgical release of the tethered cord, and once released, this can reoccur. Chiari-2 malformation. So this is usually evident at birth, but is it's usually evident at birth and is associated with myelomeningocele, but it can be asymptomatic at that time. This is compression and herniation of the midbrain and the cerebellum into the spinal cord or up into the middle fossa. Review of shunt malfunction as a cause for increased cerebral pressure is important. And then decompression of Chiari-2 is done surgically once the shunt malfunction has been excluded as a cause. Hydromyelia is a buildup of central canal of the spinal cord. It's a buildup of fluid in the central canal of the spinal cord, It occurs as a result of hydrocephalus or, again, shunt malfunction. So other complications that are non-neurological include bowel complications. So MMCs can affect bowel motility and anal sphincter control. This can lead to fecal incontinence and constipation. So the use of laxatives and suppositories or enemas is used. And then it can also have urinary tract complications. So MMCs are associated with a neurogenical bladder. Changes in bladder control can be a sign of a shunt malfunction as well, or hydromyelia. Anticholinergics are used to relieve bladder pressure, and some patients do intermittent self-catheterization. This is due to most of the time MMCs being in the lumbosacral region and therefore affecting the neurological function beneath that level, which includes your bladder and bowel control. So other complications. So pressure ulcers, prevention is very important. So frequent changes in position, occupational therapy, as well as physiotherapy intervention, as these children can have paralysis from beneath the level of the lesion downwards. So prompt diagnosis of these pressure ulcers is important, and early treatment to prevent complications. And then in terms of orthopedic complications, so correction of the conditions where possible, and this is aimed at providing optimal mobility and preventing further disabilities. So like we had said, hip dysplasia, your clubfoot, and your contractures, for example. Then psychosocially, so involvement of psychologists as well as social workers from prenatal diagnosis is important to prepare the parents for caring for a child with a myelomeningocele. Treatment is chronic, therefore careful understanding of the condition and its complications will assist for better management from both the hospital part as well as management at home. Psychosocial as well, counseling and emotional support of the family is important. In terms of outcomes, children with MMCs have a likelihood of 75% to make it into young adulthood. Prognosis is largely dependent on a few factors though, namely the location of the MMC. Lumbosacral defects have a better outcome compared to higher MMCs in the thoracic or the cervical region. Shunt placement and complications thereof can also affect outcomes, as these shunts can usually need frequent revisions. And then, frequent revisions, meningitis, and tethered cord can further exacerbate a disability and lead to a poor quality of life. Majority of the deaths occur before the age of 5 years old. Of those that survive, they can have neurological impairment and restrictions in their ambulation. The likelihood of ambulation decreases with a rising spinal level defect. MMCs located in the sacrum have good ambulation outcomes. Some of the children can attend regular classes. Others will be in need of special needs schools as a result of learning disabilities. And children in which fetal repair was done have better motor function, but cognitive effects are similar to postnatal closure. And those are my references.